Well, good afternoon, everyone. We're going to be starting this afternoon session, and welcome to everyone at St. Anthony's and Secours who are being video conferenced into this meeting. I'd like to welcome Scott Kane and Associates Consulting Group, and with us today we have William Scott Kane, the CEO, founder of Scott Kane and Associates, as well as Dr. James Kyle, the Vice President of Medical Affairs. And they're going to be spending some time with us this afternoon to navigate the RAC program, the Recovery Audit Contracting Program, and especially give us specific cases and talk about the Secours system and how it applies towards our system. And we're going to try to keep this as interactive as possible. So without further ado, let me introduce Mr. Scott Kane.
Thank you. Thank you, Dr. Cockrell. Thank you all for coming. I appreciate it very much. Can everybody hear me? Everything's fine. Kane Associates has been engaged with Secours system-wide in all states for 5 or 6 years now, doing lots of different things. And one of the things that we do here at the charity system is we've been involved with the RAC program for probably a year and a half, something like that, now actively. And today we actually manage the program interaction with the RAC, with CMS, with the MAC, all the way through. So if there's a record request, we facilitate getting those record requests filled. We do the clinical review of records. We do the appeal defenses, level 1 and level 2. And as you'll see, and we'll talk about in a minute, we try to turn that knowledge into education and knowledge for you, so that interactively, we can come up with solutions and approaches to kind of dealing with this problem that is growing by leaps and bounds. Sorry. There you go. Let's just talk about some trends for a second. I guess there's two basic things that are taking place that we're seeing. One is the RAC activity is growing by leaps and bounds. I mean, it's really significantly increased in the last quarter. Here you can see, as I'm sure everyone knows, there's two different kinds of denials. They look at automated denials, which is really more data mining activity that they do. And you've seen those. They were strong in the beginning because they were easy for the RAC to do. But the growth has really dropped off to about 10% in the last quarter. If you look at complex denials, they've jumped significantly, and I'll get into in a second why that is. And then if you look at the number of medical records that's been requested, just in the last quarter alone, it's grown from 230,000 records nationally to over 300,000 records. That's about a 57% increase. So the pace is picking up very, very quickly.
So the video camera picks up your voice well.
Sorry?
That's okay. Excellent. Thank you,
If you want to try to quantify what that increase in volumes mean, in the last quarter alone, the recovery rate jumped, or the denial rate jumped for the RACs nationally from 226 million in the previous quarter to over 355 million in the current quarter. That's a significant increase, about 67%, I think, something like that. And you can see where it's taking place. By region, your region A, this is a national slide. These slides, by the way, are coming out of the AHA through the RAC program. But this is hospitals reporting all across the country the activity that's taking place. In region A, you can see the increase is pretty significant, but that is true across the board as well. So what kind of denials are they coming up with? 96% of all hospitals out there are now reporting what we call medical necessity denials. If we're looking at complex denials, which is really the focus, complex denials when you actually request a copy of a record, look at it, make a judgment. Medical necessity denials are just that, a judgment about medical necessity. The other big area has always been coding. What we've really seen in the last couple of quarters is a significant trend toward medical necessity denials and kind of a diminishing role in the other areas. Now, why would they do that? Well, according to Medicare regulation, if an account is denied in a RAC program and it's older than a year, if it's a medical necessity denial, you can't rebuild the account. Now keep in mind that when a RAC is auditing, they're auditing 3 years in arrears. So almost every account they look at for medical necessity denial means 100% loss if they win. If it's a coding denial, on the other hand, they'll get the difference between what the DRG codes might be and what the reimbursement will be. So, as we all know, RACs are incented financially. They get paid on a percent of what they recover. So 100% denial is a whole lot better than a 20 or 30% denial on an account. So you're seeing a significant push. A lot more monies are coming back into the government field as a result. And that really becomes the basis for what Dr. Kyle's going to be talking about today. If we look at medical necessity denials, what's their focus really been? It's the low-hanging fruit. It's 1- and 2 day stays. And basically, if you get into the 1- and 2 day stays, and medical necessity denials, hospitals across the country are now saying 71% of the hospitals are saying the greatest risk they have and the biggest exposure they have and where they're seeing the greatest number of denials is in medical necessity denials. So there's no question that trend is real, there's no question it's happening, and the rationale for it is there's a whole lot more money in it for the government and for the RACs if they focus there. Of those medical necessity denials, fully 63% of them pertain to wrong setting. And here's where we get into that basic whole question of inpatient, outpatient observation, how to document what to do, how to use it. And I know we have seen, and I think Dr. Kyle, who also looks at these records as they come through and defends most of them, we see over and over and over and over, 90+% of every denial that we see is being denied for medical necessity in the wrong setting. If you look at the increases just of denials in hospitals, Region A, the green basically is the current quarter, and you can see where things peaked in the other regions, A, B, or B, C, and D, but Region A is still growing, and we're certainly seeing that around the state of New York and in some of the corresponding states. But you're seeing probably the largest increase in medical necessity denials are taking place, the complex denials are taking place in Region A today. So, you know, in the last quarter, there were almost 15,000 of those. If you think about it, and you think about the trend, how do we defend ourselves, what do? We have to learn to utilize inpatient, outpatient observation questions. You have to document accordingly, and we need to change that going forward. You realize there's always going to be the fight going backwards. But there have also been some recent reviews looking at 2011 data as well. And what we're really seeing is the same type of trends and documentation issues and things that we had seen in the earlier accounts that the RAC might be looking at 2 and 3 years old. So things really aren't that different, and I think what we really have to do as a group, working together, we have to find ways to kind of change that documentation process. And unfortunately, you know, we have to try to audit proof all the time. Changes patterns and changes work. And our approach at CNA is a few things. I mentioned we do a lot of in-depth coding reviews. What we, at coding and medical necessity reviews of records, our program takes all of the CMS-approved audit issues that RACs are allowed to audit for. Before a RAC can audit for a given issue, it has to be approved by CMS, and those get published. So, and each RAC has its own set of approved CMS issues. We go through each of those issues, we rate them, we look at them according to trying to determine what the greatest exposure is for a specific hospital, and that really has a lot to do with patient mix. You end up with, we prioritize by what's hot with the RAC right now, We also look at it in terms of dollars or the weight given to a specific diagnosis and the frequency. And with that, then we set up sampling of accounts that allow us to go in, look at, make a judgment about the record. And then the last one here, we create specific education programs that just target specific issues that are not they're specific to the individual facility and the practitioners that are functioning there. And then naturally, that attacks the going forward and stop the bleeding and moving ahead. But then we have a very aggressive program, and at charity, if there's a denial, it's appealed, period. And you can say, well, why would you do that with all of them? Well, the government also has this little thing they call extrapolation, and they're beginning and pushing RACs to use it more and more. And what it means is you might have say you have a lab charge or lab reimbursement that gets denied and it was $200. You wouldn't think you'd spend the time and money to go in and try to resolve that. But with extrapolation, what they do is if they see a pattern with that particular situation, then they go in and they'll extrapolate across the entire patient base and say that $200 might turn out to be for 5,000 patients. So now it gets to be a big number. So you have to fight the issues. So we try to focus on fixing things going forward, stopping the bleeding, providing the information necessary for people to make those decisions on their own. We don't try to say this is how you have to do it. We try to put forth the information and say how should it all best be done. Those are your decisions, not ours. I'm going to let Dr. Kyle at this point. That kind of sets the stage, hopefully, and you can see the downside, the risk is huge, and I can tell you the numbers here. We've seen in the last quarter, just looking at actual RAC findings and numbers of RAC accounts that are in play here, have doubled. We now have almost $1 million worth of appeals in play. We have about 900 appeals active. And we probably have at risk and in process another $4 to $5 million that still being looked at and moving forward. So these are very real numbers and very meaningful numbers. With that, I'm going to let Dr. Kyle take over. Yes, sir.
Good afternoon. You seem like such a somber group. So let me start off with a story that would be applicable to what we're talking about. This is the holiday season, and a man once, he bought a parakeet. And it was a beautiful parakeet. He brought the parakeet home, but then he noticed that the parakeet had some bad habits. It was a cussing parakeet. Every time the man looked around, the parakeet was just cussing and cussing and cussing. So the man did everything he could. He talked to the parakeet. He tried to feed the parakeet better food. He shook the parakeet once, and the parakeet just cursed him even more. So he said, I don't know what to do with this parakeet. I'm going to take the parakeet, I'm going to put him in the freezer. So he put the parakeet in the freezer, and he heard the parakeet inside the freezer just cussing away and cussing away. Then suddenly became deathly quiet. And the man became fearful that he may have harmed the parakeet. So he opened the door to let the parakeet out. And the parakeet walked out very calmly, looked up at his owner and said, Sir, I'd like to apologize for all the bad things I've said to you. I realize that my behavior was just unacceptable. And would you please forgive me for my behavior? And the man said, well, sure. And then the parrot said, but I have one question for you. I said, what is that? What did the turkey do? And really, that's what we're going to talk about today. Because what has happened to healthcare as we know it is what happened to that turkey. There are forces that are working now to put healthcare as we know it on deep freeze and basically dead. And we have to recognize that we're fighting against an uphill battle that we can win, but we have to win it by being much smarter than what we've been in the past and much more intentional about what we've done in the past. So our real issue is when to admit, when not to admit, and how do we avoid denials. So let me make some basic principles. For years, as a physician, I would look at my patients and I would do what was either in their best interest in terms of convenience around their care and workup, or sometimes what was in my best interest in terms of my schedule, my time, So when the doctor looks at a patient at 10 o'clock at night who comes in with some chest pain or comes in with some abdominal pain, you want to do a workup, you admit them to the hospital, you know you're going to come back the next day and check on them, and the workup should be moving ahead as the morning progresses, and that's how we used to practice medicine. That's no longer reimbursable. The other thing to keep in mind is that compliance is no longer intuitive. The way regulations are written by CMS, what you would naturally think to do is no longer what is necessarily approved or is compliant. It is no longer an intuitive business. The thing that you certainly will see, common sense may not always prevail with CMS. We are talking about the government. When have you known the government to necessarily be a big proponent of common sense? And so there are going to be some issues you're going to face. Physicians must become comfortable with the use of the observation status, and we're going to talk more about that, until you have a definitive diagnosis. And observation status is not a holding platform where you just walk and turn away. CMS requires observation to be active observation, and I'll explain to you what I mean by that in a few minutes. And what you write in a chart, or what you don't write in the chart, will be held against you. Now keep in mind, we're about to move from ICD-9 to ICD-10. I'm not sure if you've had a presentation on ICD-10. We'll be happy to come back and provide that for you. But the number of codes that a patient encounter can be billed by now will jump exponentially in ICD-10. So the specificity with which you write and document will become even that much more important. And you'll find that there will be millions of dollars left on the table if you're not really explicit in what you write, so the coders can explicitly find that. And so we are finding things in the chart that shouldn't be there. I'll give you a classic example, not from your charts. I'm going to talk about your chart specifically. I was looking at a chart in my hospital, and the physician wrote an order, and then he wrote a note over his order because he was angry at the pharmacy and said, "Do this because I said so." Okay? And I sat with the doctor and said, you know, I'm not sure that legally you want this particular note showing up in court. But people sometimes don't think about the fact that whatever's in that medical record, it is a legal document and will be used forever to understand the care of that patient. So let's look at some examples. We'll talk, now these patients come from this hospital or the hospitals here in the Good Sam area. These are patients that have been seen recently, and these are what the doctors saw and wrote and documented. So he had an 80-year-old male. This male presented with some dyspnea, shortness of breath. There was a history of a recent pleural effusion, and they had been tapped and already had the effusion drawn down in a previous hospital stay. The patient had a history of renal failure and was on chronic outpatient renal hemodialysis. On exam, the patient comes in, he has normal vitals, his oxygen saturation on room air is 92%. His exam is completely normal except for trace pedal edema. The creatinine, hemoglobin, hemocreatinine, you can see there, basically within pretty normal limits. Chest x-ray showed a slight, small right pleural effusion, but he documents in his note that the pleural effusion was decreased in size from the previous day. Okay? Now here's what the doctor writes in his subjective findings. He says at this point, the patient is asymptomatic. Now is that the word you want to use when you're about to try to admit somebody to the hospital?
No.
The patient is asymptomatic, or his symptoms really did not change. So I did not think there is an indication for another thoracentesis. So what brought the patient in the hospital before was a pleural effusion so large that they had to do a thoracentesis to allow the patient to be able to breathe properly. He now says, I don't think this patient needs another thoracentesis. He feels good. He is just complaining of some fatigue. Today he denied worsening dyspnea in comparison with the last admission. Okay? Here's what CMS, the RAC auditors, said when they got this case. It says, at the time of the physician's assessment and plan, it was end-stage renal disease, transfusion-dependent pleural effusion, pulmonary evaluation, hypertension, continued recurrent medication. This is what the doctor wrote as his plan for this patient, right? So here's what CMS says. In summary, the patient's severity of illness upon presentation did not necessitate an intensity of service for inpatient admission by Medicare criteria. The patient was admitted for a blood transfusion and hemodialysis. This plan of care could have been implemented for and completed within 24 hours. So let me give you these highlights. The first thing CMS looks at is intensity or severity of illness. How sick is this patient? And does their severity of illness warrant them being confined in a hospital? They also look at the intensity of the service you're going to provide. So if in this case, all they did was give this patient a blood transfusion, and they did that at the time of dialysis. Well, we do that all the time on an outpatient basis. There's no need for someone to be hospitalized for anemia if they're going to get a blood transfusion on a hemodialysis machine. So what they look at is the severity and the intensity, and then they're trying to decide, have you got the right setting for care for this patient? They also look at what happens in the first 24 hours. And what their point is here, could you have observed this patient on an outpatient status, which, by the way, observation is not an inpatient status. Observation is an outpatient status. Could this patient have been observed on an outpatient status, transfused, reassessed by a follow-up H&H, and then sent home? If the patient somehow did not respond to transfusion, or you notice while they're there, they actually were having active GI bleeding, then you would have the opportunity to switch from observation to inpatient. And they would have accepted that admission. Now, obviously you don't want to have, I guess, an over-exuberant use of observation when it's not indicated. Some of these patients actually need to be sent home from the ED. But when you're not sure, and physicians are trained this way, Doc, you understand what I'm saying? Our basic concern is what's the safest thing to do for this patient? We get caught on our concerns for safety by using the wrong setting for the care of the patient. If we said, I'm not sure this patient's ready to go home, I'm not comfortable sending them home, that's the patient you observe. But then you set up strict criteria for what are you observing and how do you monitor it. And you just can't walk away from the observation. Sometimes you have to say, okay, I want something checked in 6 hours, I want something checked in 2 hours, and I want to be called to know what those results are if they're out of certain parameters. You set up in a way so that ongoing active monitoring is happening while the patient's on observation, which says to CMS, okay, you were really observing this patient and you were going to send them home as soon as was possible. Let's take a look at another patient. This is one of your patients, a 75-year-old male. He had a history of COPD, SVT, paroxysmal atrial fibrillation, cardioversion, presenting with exertional dyspnea at this time. So the patient is basically short of breath every time they move. The patient was walking without his oxygen turned on. So if you've got a history of COPD and you're walking around without your oxygen turned on, are you likely to be a little dyspneic on exertion? This note, by the way, was observed by the physician on the outpatient basis who happened to see the patient in his office, walking down the hall. They noticed the patient was short of breath, okay? So his doctor referred him to the hospital, even though he felt better when he turned his oxygen on. So the doctor said, why's your oxygen off? He said, I don't know. He said, well, turn it on. So the patient turns his oxygen on. He says, yeah, I feel better. But the doctor says, you better go to the hospital and be checked out. Okay, I'll grant you want to make sure the patient was okay. So here's the exam of the patient. He comes in now with his oxygen turned on. He has normal vitals. His O2 sat on room air is what? 96% and 94% even when they walked him. They exerted him and he still has a 94% O2 sat. He has decreased breath sounds in his bases. His normal labs and EKG are there. And his chest x-ray shows basically COPD, long-term COPD player. At the time of admission, the physician's assessment was, this is what the doctor wrote on the admitting forms, increased shortness of breath in humid air with no O2, most likely from worsening chronic obstructive pulmonary disease. Doubt that he has an infection. Doubt that he needs prolonged stay in the hospital. CMS is saying, what do you mean by prolonged? 10 minutes? An hour? What's prolonged? So here's the plan. Admit for IV Solu-Medrol. We'll monitor respiratory status, increase ambulation, and if tolerated, we'll send the patient home. Is that a reasonable plan? I don't think that's an unreasonable plan. I mean, the patient was having a worsening of a chronic illness. This is an exacerbation of his COPD. The doctor wants to therefore treat that exacerbation. You probably wouldn't send the patient based on his exam home, but yet he has normal O2 sats, both on room air and normal O2 sat when you ambulate him. So if he needs treatment, it is not extended treatment, and PROPS does not measure up to the criteria for admission. So here's what CMS said about this patient. In summary, the patients, again, hear those words, severity of illness upon presentation did not necessitate an intensity of service for inpatient admissions to Medicare criteria. They always use that line for these short stay admissions. The patient was admitted for chronic obstructive pulmonary disease. The plan of care could have been implemented and completed within 24 hours. And what they're really saying is you could have put this patient on observation, treated them with the Solu-Medrol, treated them with other respiratory inhalers, reassessed how well the patient feels, and sent the patient home as outpatient. Yes, sir.
So, as you depicted, the diagnosis for the physician was COPD. Exacerbation.
Yeah.
Now, if the physical exam, you could apply this to almost anyone, every situation varies, but if it exemplified or showed an excessive wheezing and accessory muscle use, the question is, your documentation then sort of, would that would change the plan here and justify it?
Absolutely. If he had documented, accessory muscle use, so you're now concerned that the patient's going to become very tachypnic and worsen, or if he had actually done a blood gas,
right,
to demonstrate what the CO2 retention may have been in this patient, but he didn't. So based on what they had to go on, CMS says you don't have enough to justify an admission. So if you really think this patient needs to be hospitalized, then you might want to do a little more in terms of the diagnostics while under the observation status to justify the hospital stay, or in the ER before the decision is made to admit or not to admit.
So it verifies what you were saying, what you exclude is as important as what you include.
Absolutely. And many times doctors will see what's going on in the patient. They know exactly what they're thinking, they just don't write it. And because they don't write it, when someone looks at your chart in the cold light of fluorescent office someplace, and they look at it, they don't know what was going on at the time they saw the patient. They only know what you documented. And then they respond to what you documented. And that's why they give us these denials. Yeah, in fact, legally, what you didn't document never even happened. It was never done. Can I show you a couple more? Is that okay? Yeah. Patient C. I don't know why I picked on men. I didn't mean to exclude. I think I do have a woman somewhere here. Patient C, a 60-year-old male who presents with profound weakness, lasting for a few hours with dizziness, no chest pain, no chest pressure, but he was scheduled for a cath anyhow. So he comes in, he's already scheduled for a catheterization, cardiac cath, but he now has some profound weakness and a little dizziness. They examine his past medical history. He has severe COPD, he already has paroxysmal atrial fib, he has coronary artery disease, he had an angioplasty with a stent placed in the RCA about 10 years before. He had an echo a year before that was within normal limits. So here's his exam. His exam is, he has absolutely normal vitals. O2 sat is 96%, but he does have bilateral expiratory wheezing in all of his lung fields, but other than that, his labs and his EKG are normal. So what you have is a clinical finding as a man who has profound weakness, some dizziness, who also has expiratory wheezing. So here's what is written in the doctor's note. 60-year-old male with history of coronary artery disease and recent episode of profound weakness and diaphoresis. Here's his differential diagnosis on the patient. He has hyperlipidemia and blockers. He's currently a heavy smoker. He has a family history of coronary artery disease. He has paroxysmal atrial fib, prior percutaneous coronary intervention to the right. Now, a lot of physicians sometimes, when they write the differential, they just recapsulize the history of the patient. And they presume that these past medical problems are active medical problems today. They actually may not be active, but they are a part of the patient's history. Listing every part of the patient's history in the differential for what you're planning on doing for the patient does not make the patient more admissible for inpatient stay. And in fact, it now forces you to write even more as to, so what? The question comes from the reviewer. So the fact that the patient is a current heavy smoker means what? What are we trying to say by that? And so the more we put, and this is sometimes a knee-jerk thing that happens, especially when you're tired. You just start writing stuff on the chart because you want to go home. And it fills up space nicely. Here's the plan. The plan is to do a left heart catheterization, which we know was already what? It was already scheduled, if necessary. An angioplasty would be done if necessary. Risk, benefits, and alternatives have been discussed with the patient and his wife. Smoking cessation counseling was provided in detail. Sleep study as an outpatient was recommended, as well as colonoscopy for cancer detection. All important things that have happened from a risk reduction point of view, not pertinent to the admission. But now let me ask you a question. Is cardiac cath an inpatient diagnosis? Diagnostic cardiac cath? I have to tell you that many cardiologists disagree. And they're admitting every one of their cardiac cath patients for at least a day. CMS does not support that at all. Diagnostic cardiac catheterization is considered an outpatient procedure. Shockingly, a lap chole is an outpatient procedure. And you would think that anytime somebody opens your belly, no matter what they're going to do, you at least have bought yourself a hospital day. That would be intuitive. It's no longer true. This patient should never have been placed on inpatient status. The procedure was performed without complications. They did a PTCA and they stented the circumflex artery. This type of procedure is frequently associated, and this is what CMS is saying, this procedure is frequently associated with the expectation of a brief stay, less than 12 hours, which means CMS will pay for observation after the cardiac cath. Watch the patient on an outpatient basis for less than 24 hours, unless serious complications occur or pathology is uncovered. So indeed, if there had been a complication, then they would have approved the movement of this patient directly into inpatient status. So if he had had significant runs of VTAC as a part of the cardiac cath, and now was presenting with unstable rhythms, then you would have put this patient on a tele bed, and you would have been able to put them on an inpatient status without a problem. But this patient went through the procedure without any problems at all. So they basically denied it. Can I give you one more? Then I'm going to move you on to some points I'm going to open up for discussion. Yes, ma'am.
Doctor, do they deny it, or do they, and then you have to appeal it, or do they deny it and pay at the status that it should have been?
Well, you know, this is a this medical necessity of care. So essentially, they just deny it and keep the money.
If, for example, it was within a year's of date of service and they were auditing that, then you would have the opportunity to rebuild that account. If it's older than a year, and this was a change in Medicare regulation that took place about a year ago, just as they were getting into the program and cranking it up, it does make you wonder why they made the change, considering they're auditing everything 3 years back.
Mm-hmm.
But the difference between a DRG validation finding and a medical necessity finding is if it's older than a year, you cannot rebuild a medical necessity finding. So you would lose 100% of whatever that is.
Which would be significant because the rate, as you know, for inpatient versus observation is much different. You get less for the observation stay, so you have to pay back more for the inpatient stay that is seen as inappropriate. Yes, sir.
And does this apply, once again, strictly to Medicare? I mean, usually other insurers follow what Medicare.
Well, here's our belief. Right now, we're talking about Medicare. This is CMS, the RAC audits. As you've seen in the history of healthcare, the commercial payers follow behind. Now, they don't have the authority of a RAC auditor to go back and take stuff from you retroactively or to all that, but you can expect that you're going to have traces of the same kind of attitude happening in the commercial payers also.
Well, on the Medicaid side of the world, you know, you have the Medicaid RACs. The states have been trying to get moving, and the IPRO actually has the contract in New York to do that. It hasn't been very active. We are also involved in all things IPRO, so if there are issues in medical record issues or requests or defenses, we do those as well. But with the new federal Medicare RAC program, it's been announced that program will follow the same basis as the Medicare RAC program. So you can expect this same kind of thing to happen. In some respects, that's good because we know the rules. in a lot of these other audits that are coming through, like the OIG, for example, Medicaid OIG, they don't have rules. They can do whatever they want. There's no time frames they have to adhere to. I mean, they can literally do whatever they want, and you have to prove them wrong. At least in the Medicare RAC and soon-to-be Medicaid RAC on the federal level, at least we have, they may be the kindest and gentlest of all. At least we know the rules we have to play by. They're terrible, but we still have to. We know what they are.
So with the non-Medicare, like a couple days ago, I had a 50-year-old patient, diagnosis X, I put on observation status. The question is, if it's not Medicare, should we approach it the same way with those patients?
My thought is that it's really tough. It's not impossible. It's really tough to practice medicine in multiple ways. I think you're best suited to treat all your patients the way you have to treat a Medicare patient, because that way you get the discipline, you get the experience of that, and it doesn't cause your own confusion. The other thing that the auditors are looking at, and this is really from generally states will do this with their own Medicare or Medi-Cal programs. If they see a pattern of treating public patients different than private patients, you'll have a problem.
That's especially true with Medicaid programs around the country. Yeah. And we see that. It's in the press. You see it happen.
So you need to establish a standard. And I think the standard really is predicated not on the payers. The standard should be predicated on quality care and driven by protocols of how we appropriately treat patients. And that's the best way to go. But to try to create a standard for Medicare versus a standard for Medicaid versus a standard for commercial, first of all, it's just too confusing, but it is also illegal. It gets you in trouble. Let's deal with this last patient. I'm going to give you some closing remarks and we'll open up for some real dialogue. We want this to be interactive because I know you're facing issues every day that you're puzzled about. And what we wanted to kind of show you is how your work is being treated by CMS RAC auditors right now. A 79-year-old male presented with dizziness and he had fallen to the ground. He said he had no head injury. There was no loss of consciousness. But he now was too dizzy to ambulate. So I want you to get this picture. The patient says, hey, I'm okay. But every time they stood him up, he was so dizzy, he could not walk, okay? Now, he had a past history, though, of vertigo. So you already have somebody who has chronic vertigo. He's also diabetic, which means, he has microvascular disease. And he has hypertension. He came in, his blood pressure was somewhat up, 160/76, but for someone with a history of hypertension, that's not necessarily that critical. His pulse was a little elevated at 102. His O2 sat was normal, however, at 93. They did a CT scan of his head. They found moderate atrophy for someone of his age of 79, with mild small vessel ischemic change, but no acute infarct, no hemorrhage, no subdural, nothing that would look like a traumatic injury from his fall. They checked labs. His glucose was up at 322, but he has a history of diabetes, so he's not a new onset diabetic. His troponins were normal. His chest x-ray was also normal. And they rechecked his finger stick and his glucose had already fallen to 278. So this is how the patient presents. Here's what the physician felt in his assessment, or her assessment. Pre-syncope with severe dizziness. And now they're making a diagnosis based, and this is a clinical assumption, vertebral basilar insufficiency versus arrhythmia. Now, I'm not sure where that diagnosis came from. I mean, we don't have any documentation that was in the chart we could find of arrhythmia. But there's a presumption that, well, they were dizzy and the dizziness had a sudden onset, so maybe it was caused by an arrhythmia. And the vertebral basilar insufficiency, well, that may be the case, but based on what? I mean, we saw the CT scan. How do you diagnose vertebral basilar insufficiency right away? Can you do that off a CT scan? You really can't make that diagnosis off a CT scan. You have people without a cerebral angiogram or some other kind of modality, you can't make that diagnosis. So we have two presumed diagnoses. And it says, what is the plan? We're going to put the patient on telemetry. We're going to do an echocardiogram. We're going to ask neurology to come in and see the patient. We're going to do a cardiology consult. Now, in the real world, this patient presented to your office. You could have arranged all these consults as outpatient, on an outpatient basis. Now, here's where I talked about convenience not being reimbursable. I understand what this gentleman's trying to do, or lady's trying to do. The patient's here. I got him right here. I got a cardiologist, I got a neurologist, I had all the testing equipment right here in the hospital. Why would I send the patient out into the, quote, real world where they have to do what? Wait for their HMO to approve their CT scan? So out of convenience for the patient, out of convenience for the physician to get an answer, they admit the patient so they can run the test. They get the consultants to come in. The hypertension is going to continue the patient on the medications, and they're going to do something about the diabetes, and says further management will depend on the clinical course and result of the workup. Well, that's the right answer. Wrong status. The status they made the patient was inpatient. What they could have done is make this patient outpatient and did the exact same workup. And then based on the results of the workup, they could have decided, I'm going to send the patient home, or I'm going to keep the patient in the hospital for an inpatient stay, because now we found something devastating that we need to treat. Severity, severity, intensity. Does the patient meet severity intensity requirements to be in a hospital? So here's what CMS said about this patient. And I wrote out the whole thing, but I'll just hit you some highlights. The patient's severity of illness presentation did not necessitate services. I mean, basically the same message. He was admitted for dizziness. The plan of care could have been implemented and completed within 24 hours. But they're basically saying observation. This patient didn't need to be admitted. These are the one-day stays, and these represent 63% of everything that they're holding back. And what we're seeing in terms of our review of your documents, this is just common. I picked these at random, but I could have brought you another 100 of these. One-day stays are they're just killing us on the one-day stays. By the way, this pattern will change over time. Right now, this is low-hanging fruit. On medical necessity, they're easy to hit. Wait till they start looking at your longer stays. And at the longer stays, what they're going to focus on are those last 3 days of the stay or 4 days of the stay. You know, when the doctor writes in his progress note, patient ready for discharge, we'll just take out your checkbook from that point on. Because from that day forward, if you said on Thursday the patient was ready for discharge, but the patient didn't go home until Monday, they're not going to pay for those days. They're going to deny those days. They'll deny days where, and sometimes they'll deny the front end of the case, but then sometimes patients get sicker in our care, and then they now qualify for inpatient care, so they'll say, okay, from this date forward, we'll pay, but we're not going to pay for these first few days. The person needs to be in the hospital. And heaven forbid that we iatrogenically extend the patient's stay. Then we get to the Never 28 and the other kind of things where they withdraw. The other process we're seeing in Virginia and other parts of the country, we've told you about it, it's finally starting to happen. The inpatient denial, let's say this patient was denied for a 1-day stay or a 15-day stay. The inpatient denial is now being tagged and tracked to the physician, not just the hospital. So the physician's reimbursement for that stay from Medicare on a stay that was denied for inpatient status, they're now coming after the doctor to get the doctor's reimbursement back.
We got word last week, I guess it was, that's actually happening within the Secours Medical Group in the state of Virginia. The RAC has finally become active there, and they've become active not only with the 7 hospitals, but also with the large physician group, the statewide group. They have several hundred doctors that they're reaching through.
Physicians for years have said it'll never happen. It can't happen. This is America.
Oh, it's happening.
I see a hand here, and I come to your hand. Yes, ma'am.
Okay. Doctor, you mentioned Medicare denying, parts of the length of stay, but being paid by a DRG, if the patient meets the criteria for inpatient stay,
Right.
then it's your loss for keeping somebody
Right.
way beyond, the
You just lose the money.
expected. Exactly.
Right,
But
right,
they can't take that back
right.
once the admission piece has been approved.
You know, there are hospitals that have part of their business that are DRG, and part of their business is case rate related to, or a daily rate related to the payer who's paying. That's why I'm saying the commercials will start pulling off the same thing.
Yeah, that I understand.
Depending on what
But
kind of
Medicare-
contract you have. But on your DRGs, you're right, the only persons that are really losing is you by expending more services. Now, the big issue I think you're going to face is communicating with medical staff. It's wonderful you have hospitalists because they can understand this very quickly, but the rest of your medical staff may have a hard time understanding the utilization component of this whole process. I have doctors who feel like I have a surgeon who every post-op patient he has, he wants to put that post-op patient on telemetry. Not because the patient needs to be monitored from a cardiac point of view, he likes the nursing care in the tele unit.
That sounds familiar.
There are better nurses in tele than there are in other places. So he puts every post-op patient in tele. And what I've told him is that you're taking up a valuable resource to our community. Our hospital frequently runs at 115% of occupancy for months at a time. Just one of those anomalies of where we are in the high desert. So a tele bed for us is as precious as gold because we have people who actually need that bed, not a stable post-op patient. So getting that whole utilization piece done really goes back to the question. It's not about payer class. It's about what is solid medical practice, because that's what saves us in the end. There's no need trying to confuse our doctors or our nurses. We're trying to figure out, well, this is a Medicare patient versus a Medicaid patient versus a commercial. This is DRG. This is capped. All that's inconsequential. What is the right thing to happen for the patient? So it's the right care in the right amount, in the right setting, at the right time. And those are the things that will save us. Let me just close with a few comments and then we'll open up for discussion. All what you've seen today have been one-day admissions. The severity of illness did not meet Medicare's inpatient criteria. The physicians frequently attempted a diagnostic workup that could have been done as an outpatient under observation status. And most cardiac procedures that I mentioned before are considered outpatient. So what's coming our way, and this, some of us already here, there's going to be heightened scrutiny on all short-term stays and outpatient procedures admitted to the hospital. Already CMS is linking physician billing to the inpatient denied days and will take back physician reimbursements on denied days, or basically, and they do that prospectively. In other words, they look at what they need to take from you now and they just deduct it from what you're going to bill later. So they always stay kind of ahead of you. And hospitals need to follow CMS guidelines to avoid auditors' denials and that's the basis of policy. So here's what we're going to recommend on how to avoid these denials. Do you use Interpol here or Milliman? Interpol.
Possibly going to Milliman though from our corporate offices looking at that.
Okay. I would recommend that physicians and case managers work closer together around these guidelines, especially in the early hours of an admission. It just saves you time and possibly saves the hospital and the physicians money later on to make sure that your patients meet. Now, these are not holy grail. There are times where clinically you can disagree with Milliman or Interpol for solid reasons. But for the most part, they're pretty accurate around what's going to be paid for. We need to raise the bar for inpatient status to patients who could not be safely evaluated or safely treated as outpatients. Those are the folks who need to be put in a hospital under inpatient status. If you're still a little concerned, you can bring them in a hospital under outpatient observation status, which some people have referred to historically as inpatient, outpatient in a bed. But you can't use the word admit. Now, quite frankly, we have found that in many hospitals, what really gets doctors in trouble is that on the admission forms, there are no options. You know, if the form said, actually on the pre-printed form, observation, inpatient, admit to, then they can check the right box. But if it just says admit, and the doctor forgets to say admit to outpatient, then they wind up being admitted by default to inpatient status. So one of the things is just